We must continue to take every action we can to protect our loved ones and our communities. One of the simple things we can all do, one thing that will make the biggest difference, is to wear a mask. I know some of you are both tired of hearing about masks as well as tired of wearing them. Masks can be cumbersome, they can be inconvenient. And I also know that many of you still have questions about masks. You may be unsure if they work, what kind is best, and whether 2 masks are better than 1. We've learned a lot about masks over the past year. Today, I want to share with you some new science that is emerging about masks and what we know now that we didn't know when the pandemic started. The science is clear. Everyone needs to be wearing a mask when they are in public or when they are in their own home, but with people who do not live in their household. This is especially true with our ongoing concern about new variants spreading in the United States. Masks offer 2 kinds of protection. When I wear a mask, it protects you and it protects me. But to get the most protection possible, we all have to wear them. Research has demonstrated that COVID-19 infections and deaths have decreased when policies that require everyone to wear a mask have been implemented. So with cases, hospitalizations, and deaths still very high, now is not the time to roll back mask requirements. I have also seen very many well-meaning people wearing masks that do not fit well or fit incorrectly. In fact, recent survey data from Porter Novelli found that among adults who reported wearing masks in the past week, half said they wore their masks incorrectly in public. New data released from CDC today underscore the importance of wearing a mask correctly and making sure it fits closely and snugly over your nose and mouth. In this new study, researchers used experiments in the laboratory, not the real world, to assess how different strategies to improve the fit of masks impacts a mask's ability to block aerosolized particles emitted during a simulated cough, as well as to reduce exposure to aerosol particles emitted during simulated breathing. The size of the aerosol particles in the experiment were designed to mimic the respiratory droplet particles most important for person-to-person transmission of SARS-CoV-2, the virus that causes COVID-19. Specifically, the experiments compared the performance of no mask, a single cloth face mask, and a single medical procedure mask with 2 approaches to improve the mask fit of the surgical mask: wearing a cloth mask over the procedure mask and knotting and tucking the ear loops of the medical procedure mask. In the study, wearing any type of mask performed significantly better than not wearing a mask. And well-fitting masks provided the greatest performance both at blocking emitted aerosols and exposure of aerosols to the receiver. In the breathing experiment, having both the source and the receiver wear masks modified to fit better reduced the receiver's exposure by more than 95% compared to no mask at all. These experimental data reinforce CDC's prior guidance that everyone 2 years of age or older should wear a mask when in public and around others in the home not living with you. We continue to recommend that masks should have 2 or more layers, completely cover your nose and mouth, and fit snugly against your nose and the sides of your face. I want to be clear that these new scientific data released today do not change the specific recommendations about who should wear a mask or when they should wear one. But they do provide new information on why wearing a well-fitting mask is so important to protect you and others. Based on this new information, the CDC is updating the mask information for the public on the CDC website to provide new options on how to improve mask fit. This includes wearing a mask with a moldable nose wire, knotting the ear loops on your mask, or wearing a cloth mask over a procedure or disposable mask. There are also new options available to consumers called mask fitters, small reusable devices that cinch a cloth or medical mask and that can create a tighter fit against the face and thus improve mask performance. The bottom line is this: masks work and they work best when they have a good fit and are worn correctly. Importantly, as per our usual guidance, masks should be used in combination with other prevention measures to offer you and your community the most protection from COVID-19. Stay at least 6 feet apart from other people you don't live with, avoid crowds and travel, and wash your hands often. When we take all of these prevention steps and wear masks that fit well, we protect ourselves and we take care of each other. I also want to follow up on a question I received during Monday's briefing from Caitlin Collins. I was asked about CDC's best estimate on the prevalence of variant cases in the United States, based on current case data and volume of sequencing. Our latest estimate nationally is that between 1% and 4% of cases in the United States are due to the B.1.1.7 variant, the variant most frequently found in the United States. It's important to note that some states have seen higher numbers of variant cases, and thus the proportion attributable to B.1.1.7 in these states is likely to be higher than in other states. We do not believe the variants are distributed equally across the country at this time. And with that, I will say thank you, and I will look forward to your questions and pass it back to Dr. Fauci. Dr. Fauci?
Thank you very much, Dr. Walensky. I would like to just take a couple of minutes to preemptively answer 3 types of questions that I have been asked over the last several days that I believe are important to address preemptively because they will come up. The first relates to the fact that many states, cities, and locations who have gone from 1A to 1B will soon or have already gone into the 1C of the phase. Within 1C are persons 16 to 64 years of age with underlying conditions, including those that might be immunosuppressed because of certain drugs, such as glucocorticoids or corticosteroids for diseases like autoinflammatory diseases or allergic diseases. There has been a number of individuals who feel that they should not get vaccinated because of those underlying conditions. I want to set the record straight for these individuals because they are more vulnerable to the more severe effects of if they do get infected. Therefore, they are the very people who should get vaccinated. When you think in terms of having an immunosuppressed state, for example, if you're on glucocorticoids for rheumatoid arthritis, or you're on some of the monoclonal antibodies that block the markers of inflammation, that under those circumstances, if that's where you are, there is not a safety issue with regard to the vaccine. Safety issues in immunosuppressed individuals relate to live attenuated vaccines, which are contraindicated in people who are immunosuppressed. There is no safety reason not to get vaccinated. So for those who are thinking of getting vaccinated or soon will come up for vaccination, this is something that would be beneficial to you. The only potential downside might be that you might not have as robust a response to the vaccine as if you had a normal immune response. But clearly, getting a less than optimum response is much better than no response at all. And I'm sure we'll be getting back to this question as more vaccines become available and more people in that category will be ready to get vaccinated. The next is the question of the vaccination of children, namely pediatrics and pregnant women. As we all know, these were not included in the original clinical trials that led to the EUA for the 2 vaccines that are currently available. But I want to point out that since the EUA and under the EUA, approximately 20,000 pregnant women have been vaccinated with no red flags, as we say, and this is being monitored by the CDC and the FDA. So that's where we're going there. With regard to children and pregnant women, as I mentioned on a prior discussion with this group, the fact remains that we will be starting clinical trials, and some have already started. We will not need to do tens of thousands of people. We will need just enough measured in hundreds to thousands for safety and whether or not we induce an immune response that is equivalent to the immune response that has been proven to be protective under the trials that have now shown to be 94 to 95% effective. And finally, the last issue relates to something that Dr. Walensky just said about the prevalence of the B117 or UK variant. The models tell us that this very well might become dominant in the United States by the end of March. That being the case, we should not despair at that, because there are things that we can do to prevent that. It is not outside of our power to do that. For example, the vaccines that we are using clearly are effective against this. We know that from in vitro correlate studies, as well as for vaccines that are other candidates. So the two things that we can do are some of the things that Dr. Walensky just mentioned: wearing of masks, avoiding congregate settings, keeping your distance, and washing your hands together when vaccine becomes available to you, to please get vaccinated. So I'll hand it back to you, Jeff.
Well, thank you, Dr. Fauci. And Dr. Nunes-Smith, I understand that you were at the end of your comments, so hopefully the technical issues are behind us and you'll be available for questions. I just want to pick up where you left off, and that is that equity is core to our strategy to put this pandemic behind us. And we're grateful to you for your expertise and leadership. Through efforts like community vaccination centers located in the hardest hit areas, mobile units, the community health center program we announced yesterday, along with efforts to build vaccine confidence, we are providing tools to communities around the country to do this work. After this briefing, Dr. Nunes-Smith and I will join Governor Cuomo to announce 2 new community vaccination centers in underserved communities in the state of New York. Another example of this work coming to life on the ground. With that, let me open it up for questions.
All right, thank you, everybody. We only have time for a couple of questions today. First, we're going to go to Bertha Coombs at NBC.
Hi, thanks very much. When you're talking about outreach in these underserved communities, one of the things that we are seeing right now is that there are several waiting lists. There are people who are already on state lists waiting, who haven't gotten access, and now the pharmacies are opening up, but those seem to be first come, first served. How are you going to try to create an equitable access for people who've already been waiting to be able to get access to these new vaccine doses coming online?
Dr. Nunes-Smith, let's see if your technical issues are resolved.
I know. Are you able to hear me?
Yes.
Yes.
Okay, great. Thank you so much for the question. You know, we are 100% committed to making sure that there is equitable access to the vaccines. And the points you raise around registration are well noted. I think there are great efforts underway. I would want to really lift up the work of community-based organizations and faith organizations and others to address really with some of these mechanisms that we've talked about today, including location of mobile units, mobile access, as well as pop-up community vaccination sites. And we're going to see more in the range of outreach, you know, with our federally qualified community health centers doing outreach to their patient populations to bring them in, as well as some of the pharmacies and others expanding ways to register through telephone and other things that I think will be really helpful. We're keeping a close eye on this, and we'll continue to circle back with updates.
And you're making sure that, for example, if there is a pharmacy in Harlem or Overtown, that the people who wind up getting those slots aren't sliding over from wealthier neighborhoods.
It is our top priority for anybody who is at yes, and it is their turn, that they're able to connect with vaccination.
Thanks.
Great, and we have time for one more question. We'll go to Laura Santonim at PBS.
Thank you so much for putting on this this presentation. Can you talk to me a little bit more, or just elaborate on the points about variant prevalence and how vaccine supplies are responding to that? Thank you.
Dr. Fauci?
Yeah, as you heard from Dr. Walensky and I alluded to, that the B117 is, becoming widespread in the United States. It varies. It isn't uniformly distributed throughout the United States. The variant that is the 351, the South African variant, has been recognized in a couple of states with just a few people, but it is very likely more prevalent than that because we don't have yet the full sequence surveillance that we'll be doing. When you're talking about the relationship between vaccination and variant, there are a couple of things that we do know. We do know that the 117, the one that is the UK, as it were, the one that we're concerned that over the next month or so it might become dominant. If you look at the antibodies that are induced by the vaccines that we use, they do very well in vitro in the test tube against the B117 variant. Also, the J&J study, which was done in the UK and in fact was able to show that the protection against that was really quite good to the tune of about 90%. The other variant of concern is one that is a bit more problematic, and that is the one that is not yet to any great degree in the United States, although we know it's here, and that's the 351 lineage variant, which is the one that is dominating in South Africa. When you do those in vitro studies of looking at the antibodies that you induce by the vaccines that we use, there's about a 5 to 6-fold diminution in efficacy against that. Fortunately, it stays within the realm of protection. So there is a degree of protection, even though it's diminished somewhat. The good news that we got from other trials, particularly in South Africa, is that even though there was diminution in the effect of protection against mild to moderate disease, when you looked at serious disease, severe disease, particularly hospitalizations and deaths, there was rather substantial protection. In fact, with no hospitalizations or deaths in vaccinated individuals who were infected with the 351. Bottom line is that we have vaccines that work well against it, and obviously we're going to be planning, if necessary, to upgrade vaccines in the future if we ever have to do that.
Well, thank you, Dr. Fauci, and I want to thank everybody for joining today's briefing. Thank you.